Thank you, Dr. Sultan. Thank you for the scientific committee for the invitation. So this is my case. This is a middle-aged male. He's a heavy smoker. He had a prior PCI a year ago. We don't have any document of that. He is reported to be non-compliant to his medication, especially DAPT. He was brought by Red Crescent to cath lab, and he was having new onset chest pain, and he was nauseated, and he was dizzy. This is his ECG. As you can see, there is an ST elevation in the inferior lead with a ST depression anterior lead that could represent a posterior wall involvement. He's in AFib. Also, you could see there is a PVC which related to short and long cycle. So this is his left coronary shot. You could see the LAD had a prior stent, and there is a moving haziness inside that most likely representing a thrombus. So the right coronary artery, you could see here that there is a large thrombus, there is a flow distal to it. However, it's a TIMI, one flow. As you could see also from this angio, the patient is still in AFib. He was still having a ST elevation, and he's still in pain. So what is next?
Okay. So thank you, Adel. So I'll ask my panelists here what's their bear. Start with you, Dr. Herney. So this patient came in with what seems to be, there was a thrombus in the LAD, correct, as well?
Yeah, sure.
So there was a stent in the LAD, and there is a thrombus in the LAD, and we have this large thrombus burden in the RCA. So what's your thought, Dr. Herney?
So this is a really interesting case. I think one of the key parts of this starts when we have standardized protocol is pre-treatment. And there was a little we just had a SCI document came out about management of it. There was a little controversy. Some people don't necessarily believe it, but there was just a paper in JACC that looked at all the literature and shows in pre-treatment, and is having good antiplatelet therapy on board before you get to the cath lab. So that's number one. Number two, if you don't have adequate antiplatelet on board, then I think doing a direct or Cangalor, I'm not sure if it's available or not, is super helpful. This is a case where there is obviously high thrombus burden and visible variant. So from my perspective, at that point in the cath lab, what I would do is hopefully pre-treated, use Cangalor, and then I would do it wire, and I would do, this is a case, selective thrombectomy would be what we would do.
Great. So you basically lean toward direct thrombectomy in this case. So I think others may consider treatment with medication. So I'll just go around the group and see what's their thought, and then we'll see what you've done.
Okay. So the patient was treated with pre-treated with ticagrelor.
So I would second you on that, on the pre-treatment, because that makes a big difference. And we were talking now about not just one artery problem. So we're talking about multiple thrombi. One closed the vessel and the other one is in the other direction. So thrombectomy might fix the acute problem, but you still have a generalized systematic problem. Cangalor is actually a good choice.
And to Dr. Sheda, you have a microphone beside you. Would you do the same? Would you consider just a thrombectomy, or would you defer in this case?
Yes, I will go up front, thrombectomy, aspiration thrombectomy, whatever device you have. But prior, I will give intracoronary tyrofepan or antiplatelet, trying to melt this thrombus, and then I will do aspiration before any balloon. If I can cross with thrombectomy catheter, I will go for this.
Great. I think this case doesn't seem there's a lot of complication. Dr. Mohammed Rabzoni is a cardiac surgeon. Would the presence of specific antithrombotic therapy in this case, or for example using aggrastat or tyrofepan, would that, if a patient needs to go for emergency surgery, would that alter the course of your surgery, or make your decision about how to approach patient different, or you still can manage that without a problem?
No, I think we still can manage. You stop it. It depends on the agent, but every agent has its own time period to stop. If the patient is hemodynamically stable, we still can offer surgery.
Okay, great. Dr. Ibrahim is an ICU, cardiac ICU background. Do you have a next case that is more complex from a cardiac ICU point of view? So we'll take more your opinion on that. So Dr. Adel, we'll get back to you now and tell us what you've done so far.
Okay. The patient was preloaded before he arrived to the cath lab with ticagrelor 180 and aspirin 300. And he was also given a IV heparin 5000. So we decided to start tirofiban infusion. He was given bolus and started infusion. And we decided to go for a thrombus aspiration in this patient. So multiple run of aspiration using an export catheter. And we achieved a good flow, as you can see on the right image. So we decided to stop at this moment. There is still a thrombus in the proximal to mid RCA. However, as you can see, the patient now, he is returning to sinus rhythm. You could tell sometimes from the video. And there was an ST elevation resolution, and the chest pain was resolved. Especially the patient has another thrombus also in the LAD, so we decided to treat him medically and marinate him with tirofiban and also IV heparin, and we decided to bring him back later. So we elect to defer stenting in this patient. He was stable, admitted to CCU bed with continuous monitoring, tirofiban infusion and IV heparin infusion, as well as to continue DAPT and optimal secondary prevention measure. We plan to do a relook in 2 to 3 days with imaging to decide the next step. His echo came back, ejection fraction 45-50 with inferior wall, mainly the regionality in the inferior wall with mild MR. So this is follow-up coronary angio. As you could see from this images that it's at least angiographically thrombus has resolved in the LAD. So on the right system, there is still a remaining thrombus. So at this stage, we decide to send an imaging catheter and see what's happening.
Can I hold you here, Adel, just for a second? So I just want to show of hand, based on seeing that clots in the RCA, who will go direct stenting at that time, and who will still do imaging first? So this patient come in very STEMI, you have a big clot, mostly resolved, still some clot there. So there is temptation that you go direct stenting, you stent it directly, or you could go and do an imaging, because I think the big question here, this patient came with AFib, atrial fibrillation, and he has what seems to be an embolus, not the possibility of in situ thrombus, but plaque rupture is there, but it's lower in a patient that presents with simultaneous 2 artery involvement. So if you treat them with anticoagulation, it's resolved. And if there is some remnant, maybe the way to go is to anticoagulate further, and instead of going putting some metal in a patient that may have a normal artery otherwise, or you go for imaging. What's your say, Dr. Tabi?
Well, a nice case, beautifully managed. But the point, 2 points for Dr. Timothy. The problem of STEMI guidelines that says upfront dual antiplatelet is 2B. So that's the issue. You see, if you can figure out which type of patients you'll find a large burden of a thrombus, you'd probably upfront with dual antiplatelet. But that's probably, this is an issue with the guidelines. The second point is the whole purpose of deferred stenting is to minimize the distal embolization.
Correct.
So if you achieve TIMI3 flow from the first angio, which I see there's a thrombus, but there is TIMI3 flow. For me, it doesn't make it's not a point to pass aspiration catheter, because then you just, if you do it, you just go and stent it. So if you aspirate it, just stent it. If you can't delay it, if there is TIMI3 flow, because that's the only indication to delay distal embolization. So what I would have done different, I will aspirate and stent, but well done.
So I think they did an imaging, which we will see, because I think we still have the question remaining there. Is there an actual plaque rupture in the RCA that mandate you to intervene?
Yeah.
Or this is a normal artery that has an embolus coming from possibility of left atrial appendage clot? So show us the OCT.
This is an OCT. As you can, this is a distal coming to the proximal run.
Okay.
So there is not much of significant disease. However, at the thrombus, there is what seems to be a larger atheroma as compared to distally. So we couldn't see clearly a plaque rupture here. It seems to be there. So we decide to go under a stent in this case. So this is our final result, 5/0 by 26 stent, direct stenting. So regarding deferred stenting, there is a couple of registries and the studies have looked into that. As this in deferred STEMI, which is a small study, single center, they elected to randomize the high-risk patient for no reflow, especially in the high thrombus burden patient, or they have clinical risk factor for no reflow. So in this study, they have showed successfully that deferred stenting in primary PCI reduced no reflow and increase in myocardial salvage. This is proved by MRI that done after the procedure and 6 months thereafter. So does that translated into clinical hard endpoint? So after that, the Dynamic 3 deferred trial came, and it has a more tested more patient for these approaches, that immediate stenting and deferred stenting, a little more than 1,200 patients. And it showed in the routine deferred stent implantation did not reduce the occurrence of death, heart failure, myocardial infarction, or repeat revascularization compared with the conventional PCI. However, there is some caveat in this study. Well, one thing is that they did not screen and include high-risk patient, like high thrombus burden patient. The other thing is the use of GPI in this study is around 35% only, which is the opposite that it's been done on the first STEMI, that most patient, or 100% of the patient, they receive GPI. So in conclusion, large thrombus burden is a major risk factor for no or slow flow in acute STEMI, and it increases the risk of stent thrombosis also. No reflow is associated with a poor short and long-term outcomes. And deferred stent implantation has been proposed as a strategy to allow time for reduction in coronary thrombus burden and recovery of microvascular function, as well as to prevent distal embolization. So the efficacy of deferred stenting was likely to be greatest in patients at highest risk of no or slow reflow. Larger randomized studies need to prove that point. Thank you.
Thank you, Adel. Excellent talk.